Hi, it's Dr. Centeno, and this is my talk to the CLPNA 2018 Edmonton Think Tank on the future of healthcare. And the title is Why Interventional Orthopedics Will Be the Next Interventional Cardiology. So by 2030 to 2040, most elective orthopedic surgical procedures that are common today will be relegated to the dustbin of medical history. Now, if you're an orthopedic surgeon, that's very hard to hear. So why and how? Elective orthopedic procedures that are currently performed arthroscopically will be performed percutaneously using orthobiologics. So how do I know this? Well, we do this every day. We treat thousands of patients with interventional orthopedics who have knee, hip, shoulder, foot, ankle, hand, wrist, and spine problems who are surgical candidates. And we treat them without any surgery, and they do great. So what is interventional orthopedics? To get there, it's important to note that interventional cardiology changed the landscape of cardiac care. So just a quick history lesson. When I came out of medical school in the 1980s, cardiovascular or cardiothoracic surgery was really how we dealt with the average 50-some-year-old male who had heart problems. We did bypass grafting or CABG surgeries. And that dramatically shifted through the 90s and early 2000s so that the rates of those procedures went way down, and that got replaced by interventional cardiology, floating catheters or floating whole valves, catheters to open up blocked arteries, whole valves to replace arteries without surgery. So what is interventional orthopedics? Number one, it's something that you inject that facilitates healing of orthopedic tissues. Number two, precise placement of those injectates into damaged structures of the musculoskeletal system using imaging guidance. And number three, the increasing use of percutaneous tools that allow the manipulation of tissue, some of which have yet to be invented. So what is interventional orthopedics? I'm a graphical kind of guy. I like to see things. And so let's put it in those terms. Well, we have simple injections, and then we have surgery. So simple injections into a shoulder joint or into a knee joint or a hip joint. Most of those are performed blind without any guidance, but some of them are these days performed with guidance. And then on the other end, we have surgery. So if the simple injections fail of, let's say, steroid, which we know harms and damages the joint in the long run, but can make it feel better in the short run, you go to surgery. However, interventional orthopedics is really the middle ground between those two things. So if we look at all the different structures in the hip, in the knee, and in the shoulder that can be injected, we're talking about 30 different procedures between those three joints. Each one of those procedures targets orthobiologics to a very specific spot to try to get healing in that spot. And this is something that takes a long time to learn and a long time to master. So it's really as complex as surgery, but it doesn't use arthroscopy or scalpels, but instead needles. So here's an example. This is a patient, one of my patients, who has a bone marrow lesion right here on the MRI, meaning this is an area of the bone that's weak. They've got a cartilage problem and lesion right here. Now you can see this is the surgical setup or the interventional orthopedic setup. And I'm using serum fluoroscopy, and I am placing a microtrocar right where that bone marrow lesion is, very precisely going to inject bone marrow concentrate to try to heal that portion of the damaged bone. This is injecting an ACL. There are two bands to an ACL, and this procedure alone took us many years to perfect. But how to inject stuff that can heal the ACL, again, bone marrow concentrate, into these specific bands of the ACL. This is not something you can do under ultrasound. It doesn't work well under ultrasound. And it's not something you can do blind, and the cells aren't going to magically go there like on a magic carpet ride. So they need to be placed precisely into these damaged ligaments. This is a shoulder superior labral anchor injection. So the concept here is placing cells specifically into the damaged superior labral anchor. And you can see the needle coming off on the right there, and you can see the contrast going right at that damaged superior labral anchor. Again, a very difficult, precise injection procedure to perform. So this procedure is instead of surgery. So you see here a very, very tiny needle, a 30 gauge needle, hydrodissecting around the median nerve. For scale, that's the size of a pea down here. So this is a very precise work trying to get rid of the scarring and place helpful growth factors around a damaged median nerve in a carpal tunnel syndrome patient. So again, what isn't interventional orthopedics? It's not a blind or palpation guided injection like is commonly done by orthopedic surgeons. And it's not adding orthobiologics to traditional surgeries. So what are orthobiologics? What are the different kinds of things that can be used right now to facilitate tissue healing in orthopedics? Currently allowed in the US, we have bone marrow concentrate, platelet-rich plasma, fat grafts, and microfragmented fat, cytokine-rich serums. In the future, we hope to be able to use culture-expanded allogeneic and autologous MSCs, mesenchymal stem cells, stromal vascular fraction, other stem and progenitor cells, recombinant growth factors, and exosomes. So how do the two main orthobiologic injectates work? And those are platelet-rich plasma and bone marrow concentrate. For PRP, or platelet-rich plasma, we have concentrated platelets. So we concentrate the platelets from a peripheral blood draw, and those release healing growth factors that promote local cells to repair tissue. For bone marrow concentrate, this we take from a bone marrow aspirate, which you can see on the right there, and we take out the stem cell rich fractions, and these mesenchymal stem cells can act as the general contractor for tissue repair. So what tools are available in 2018? Well, we've got some tools. We have things like obviously traditional needles, steerable needles, microtrocars, different devices to manipulate different tissues, but the tools in this area over the next 20 years are just going to explode, just like they did in interventional cardiology. So why do we need interventional orthopedics? I mean, this all seems kind of cool, right? But why do we need to do things percutaneously and not surgically? So I love how the English phrase things. This is actually from the British Medical Journal, and this is an orthopedic surgeon himself writing in, stating that the evidence base for orthopedic surgery is scandalously poor, meaning that only about 20% of the procedures currently performed every day here in Canada have any high-level evidence that they're effective. Now that's pretty amazing that 80% do not. And when I did the math of the most common orthopedic surgeries in America, and I looked at things that have been shown to be ineffective, the list is long and wide. About 60% of all orthopedic procedures that are, again, performed every day here in Canada have been shown to be ineffective in clinical trials. So today, let's just focus on 4 of the many body areas that can be treated. We'll look at knee arthritis in patients requiring knee replacement. In shoulder, we'll look at rotator cuff tears. We'll look at ACL tears. And we'll look at degenerative disc disease in the spine. So, total knee arthroplasty, aka a knee replacement. You would think, given that we have millions of these procedures that have been performed, that we would have lots of randomized controlled trial data showing that it's a good idea to amputate someone's knee joint and insert a prosthesis. In fact, we only have one randomized controlled trial to date. And if you know the NTT, which is the number to treat, that number for a really good procedure or a really good drug should be 1 to 1.5, maybe. Meaning that's the number of people that you have to treat to get a really good result. But the NTT in this study was 5 to 6 to get a 15% functional improvement. That means that you had to amputate 5 to 6 knees and insert 5 to 6 prostheses and take all of that risk to get one lousy person who would report that they had 15% or greater functional improvement. And 3 in 4 patients by 1 year felt good enough with just physical therapy that they canceled their knee replacement. So that's not great in support of knee replacement. Then comes this study, which is an analysis of 2 U.S. government-funded arthritis monitoring data sets. And what it found is that only the most severely disabled patients benefited from knee replacement, and most patients had poor functional outcomes. So they concluded that knee replacement was not cost-effective for most patients. Now, how many knee replacements are done every year in Canada? How many knee replacements are done every year in the U.S.? And yet we've got this very large study showing that it's not a cost-effective procedure. So can we replace knee arthroplasty? So I'm going to show you some data here that we've collected. And everything we're talking about is a high-dose bone marrow concentrate injection. So what that means is that we're taking bone marrow from the back of the hip area through a specialized needle called a trocar. We're then processing that in the lab to get out the stem cell fractions, and then we're re-injecting that into very specific areas of the knee, not just a generalized intra-articular injection. So this is what we call percutaneous knee arthroplasty, or Perc-Knee arthroplasty. And this is the TKA, or knee replacement rate, despite the procedure. So we have a registry where we track all of these patients. And way back when, more than a year ago, about a year and a half ago, in March of 2017, we were tracking almost 6,000 of these procedures. About 3,450 had knee OA as their primary diagnosis. And the TKA rate, despite treatment at 1 to 2 years, was about 13%, meaning 13% of patients decided to get a knee replacement despite having this injection-based procedure. Now, what was interesting about that is that this is not perfect data. This is a biased data set because most of these folks didn't want a knee replacement. So I would expect that if we were to just do this in a population where patients didn't really have a bias, what they wanted one way or the other, that this number would be higher. But even if it's double this number, or even if it's triple this number, we could save a lot of morbidity and mortality by switching from knee replacement to this type of procedure. So this is our published knee osteoarthritis research. We published a large case series of 840 patients. We've done a registry-based dosing study. And we also have a knee osteoarthritis randomized controlled trial. This was 48 patients. It's now been accepted for publication. There was a 3-month crossover with PT, a 1-to-1 allocation between the 2 groups. And we saw very nice results in all of the standard orthopedic pain and functional questionnaires. So these procedures aren't magic pixie dust. Some patients are candidates, some patients aren't candidates. And how can we tell which is which? Because that would be the mark of a true medical procedure, right? Some people are candidates, and you can do certain things to find who those people are. Well, regrettably, MRI imaging characteristics didn't help us make that decision. So we started looking deeper. We started looking at the knee microenvironment itself, meaning, if you will, the fertilizer for our stem cell type procedure. So this was basically taking a very small sample of synovial fluid, analyzing it using microarray multiplex ELISA, looking at 25 growth factors and cytokines. And we ran this rather chaotic data through a neural network tied to an outcome, a positive or negative outcome. And we got to the point where we have about an 80% accurate model of picking good responders solely based on the content of the growth factors and cytokines in the fluid in their knee. And our newest model uses 440 cytokines and growth factor levels to make this decision. So we're very excited about that, of really dialing this in and taking this from a research project to what we do every day to see if any particular person is a good or poor candidate. So now let's switch gears to rotator cuff repair. What's interesting is we have a large meta-analysis of 57 different randomized controlled trials that indicated that there was no difference in outcome between surgical repair and those who underwent physical therapy. Think about that. We have a huge meta-analysis showing that surgery isn't any better than sending someone to physical therapy. And yet, again, all across Canada and all across the US, these procedures are done on a day-to-day basis. So we developed percutaneous rotator cuff repair using platelet-rich plasma or bone marrow concentrate with very precise ultrasound guidance into these tears. And this is in general what it looks like. This is PRP being injected into a tear. This is Dr. Schultz at our office. You can see the ultrasound injection occurring right here. And you can see behind Dr. Schultz, his needle going into a very small tear within the rotator cuff tendon. So this is some of the data that we've published already. We have a large case series showing positive outcomes, and we have a randomized controlled trial underway. For the RCT, this is partial and complete non-retracted tears without osteoarthritis. We're more than halfway done with this study. And the outcomes of physical therapy versus rotator cuff percutaneous injection with ultrasound and bone marrow concentrate are quite good. These are the same score differences between the two groups. These are the pain score differences between the two groups. And this is a functional questionnaire called the DASH and the differences between the two groups. So now let's talk about knee ACL tear. Again, interesting that a meta-analysis on this topic couldn't conclude based on high-level evidence that surgical outcomes were better than just physical therapy, meaning that there was only low-quality evidence that supported most metrics in the research they looked at. So again, we have these procedures occurring all across Canada, all across the US. These have become standard of care for anyone who has an ACL tear that doesn't respond well to physical therapy and they're having a hard time getting back to sports. We don't have really great randomized controlled trial data showing that this is more effective than doing nothing. So we developed percutaneous ACL repair. So what is this? Well, we have partial ACL tears, we have full thickness non-retracted tears, and we've got full thickness retracted tears. So the ones that we're focused on are about the 70% that fall into these two categories right here. And again, we're injecting the ACL bands very precisely under fluoroscopy using bone marrow concentrate. So these are the kinds of results that we see with this procedure every day. So on the left, you can see this full thickness blown out ACL. This was called a full thickness ACL tear by the reading radiologist. The solution for this woman from Singapore was surgery. She flew to Colorado for this procedure instead. This is the 3-month MRI result, and this was read out as normal ACL. So this is actually a younger person, and sometimes this can take 6 to 9 months to heal in an older person. But for most people that are getting their ACL tears treated surgically, these are younger people. So these are the kind of things that can happen. And this woman was able to return much quicker to sports than she would have with the surgery. This is another example here of an MRI showing a complete tear and then a sequence of healing in an older patient. But to date, we've published 2 MRI case series showing excellent evidence of repair, as well as the outcomes with that. So we're making great progress in getting this published. And we have a randomized controlled trial, complete non-retracted ACL tear without other injuries. Again, about halfway or more recruited, so hopefully this will be done soon. And these are the SANE scores between the physical therapy group there and the ACL percutaneous bone marrow concentrate treated group. These are the LEFS scores, or a functional score. And these are the IKDC scores and differences between the groups. So I'd like to end this up with lumbar degenerative disc disease, a hugely expensive problem. So we have a meta-analysis on 5 RCTs that fusion is no better than conservative care, but it has a 10 to 24% serious complication rate. Again, these are procedures that are done all across Canada. They're done all across the US. They are highly profitable procedures for hospitals, for physicians. So we developed percutaneous annuloplasty. What you're going to see are patients who have chronic disc bulges and degenerative disc disease, and they're only minimally responsive to epidurals, and thus they're surgical candidates. So this is what this procedure looks like. This is Dr. Pitts in our office performing it, and it's again a precise, in this case, X-ray guided injection of stem cells into the disc annulus. So these are the kind of results that we see. This is a disc bulge patient that needed surgery and was eventually headed towards a fusion. And you see here a large disc bulge. This is not getting better with conservative care. That's the sagittal view. You can see here the axial view showing that disc bulge. And this patient is not doing well. They need constant epidural steroid injections. Those epidural steroid injections are harming the local tissue rather than helping the patient, but they're giving short-term relief. So instead, we precisely placed stem cells into this into this posterior annulus, and you can see the result here. We now have no disc bulge, and we didn't need to resort to surgery, meaning we got repair of the posterior annular wall through a very much less invasive injection without the need for surgery. So this is from a study we published showing a reduction in bulge sizes pre and post treatment. So these are the SANE scores from that same study. So where is interventional orthopedics going? Well, here's an example of what's happened thus far. In 2010, as an example, about 90% of chronic steroid-resistant tendinopathy was managed surgically. By 2018, many of these same cases are managed with PRP, and we have more non-surgeons than surgeons doing this work. So we're seeing surgical procedures move to non-surgical. And by 2020 to 2025, we're going to start seeing insurance reimbursement in the US for many of these patients. And again, really the differentiator here, what makes this explode and go from just something that is interesting and the rich can afford because they have the money to do this, to really this becoming the dominant form of care, is really insurance or in places like Canada, health system coverage. So our progress in getting IO covered by self-insured plans is really instructive. These are some of the companies below that have signed on, and these are self-insured companies in the US who have decided to make interventional orthopedics available to their employees. We started this as a pilot site in 2015. Our provider network now has about 6 million covered lives, and the selling point to them is reducing expensive, invasive, and ineffective orthopedic surgery rates. And we expect about 20 million covered lives by fourth quarter 2019. So here are my educated guesses for 2030. A 50% reduction in elective orthopedic surgery rates. Now, I know here in Canada, there are a lot of people sitting in the audience who are decision makers in this province's health system. So I would ask you to ask yourselves, what are you going to do to keep up with the US, because this is going to happen in the US, in order to be able to offer these procedures? How does that change the number of surgical ORs your hospitals need? How does that change the number of surgical beds that you need? All of that stuff needs to be considered. We will see a blended specialty. We'll see orthopedic surgeons that retrain, and we'll see non-surgeon interventionalists. And we'll see coverage for many indications, and more procedural devices will be developed. So another question for Canadian government decision makers, how are you going to cover those relatively expensive new devices that come on the market in the same way that you had to deal with the relatively expensive interventional cardiology devices that came on the market? The ability to open block arteries with balloon angioplasty, or the ability to float a new valve percutaneously. All of that's going to have to be considered by the Canadian health system. So in summary, autologous orthobiologics are likely here to stay. We've seen good results clinically based on registry and RCT data for interventional orthopedics. We have multiple other RCTs that are on the way, and interventional orthopedics is about to change everything. So thanks so much for listening, and I'll take any questions.